I'm Dr. Allan Perel, and this is Conversations in Medicine, a program dedicated to bringing cutting-edge material to the Staten Island and tri-state area. It is my pleasure to have two wonderful guests here tonight. We're going to be speaking about intensive care medicine. So especially with the COVID pandemic and people in the intensive care unit, we talk about people being in a place where intensive care is given. We're going to define that. And there's a lot of kinds of intensive care. There's intensive care unit, CCU or coronary heart issue care unit. There are burn units. I'm a neurologist, so we have a neurological intensive care unit. For babies, we have a neonatal intensive care unit. All staffed with wonderful, caring, specialized physicians and staff, nursing staff, who know how to take care of very specific problems. What's been found throughout medicine is that when you go to a specialized center, people do better. Whether it's an intensive care unit for people who might have problems that need to be an intensive care unit, and we'll talk about that, or any other unit, like a stroke unit, where patients who have strokes are cared for by physicians and nurses, rather, who are trained in taking care of people with stroke. So we're going to jump right in. I want to introduce our two wonderful guests. I have Dr. Nfonoyim, who's a close friend of mine, someone I've known for many years, is one of the best doctors I know, a wonderful individual, caring individual, and I can't say enough nice things about Jay. Jay is the vice chairman of the Department of Medicine of Richmond University Medical Center. He's the chief of the critical care units. He runs the critical care units. There's also one job I think he's probably most fond of compared to everything else. He's the chief of or the director of the residency program, where he trains doctors. And I went to a medical meeting a couple of years ago before the pandemic, and somebody tapped me on the shoulder and said, "I know you." I said, "Oh, hi." And I recognized the face, but not the name. And they said, 15 years ago, you taught me at this and this hospital, and I've now gone on to, I'm in Kentucky, and I run a major institution. And I had no greater pride. And I'm sure you, running over 100 residents every year, really have tremendous pride seeing the graduates of our program, your program that you run, and my program as chief of neurology at the hospital, really do and succeed so well. So really, congratulations.
Thank you.
And I have one of your future proteges, Dr. Francine. She's a PGY2, which is a postgraduate year 2, which is a resident in internal medicine. And I want to thank you. Thank you both for coming. And we're going to talk about intensive care medicine. And the first thing I'm going to say as to people who are physicians is, what's your training? So maybe I'll talk to Dr. Nfonoyim first and say, what does it take to be the chief of the intensive care units at a major New York City hospital? And then I'll ask Francine really what she's learning or how she's being trained to take care of critically ill patients. So Jay, we'll start off. What is your training in being an intensivist?
Yeah, my training to be an intensivist, I think what I'll do is I like to tell how the tracks that you can get to becoming an intensivist. Before you become an intensivist, you go through medical school, you go through a residency. The residency has to be in medicine. It can be in anesthesiology, or it can be in surgery. After that, you take a fellowship in critical care medicine. After completing that, and you get your certification, then you become an intensivist. So there are 3 groups of physicians, specialists that can be intensivists: surgeons, anesthesiologists, and internists.
So it's a very deep dive into it. There's a lot of education,
right,
a lot of experience is needed in order to be a good intensivist. So, and knowing a lot of things.
Right.
So now I'll talk about Francine. Francine, you're in your 2nd year, as we said, of your residency. And tell us a little bit about what your exposure is to the intensive care unit and what kind of training you have.
Right. So I actually just completed 2 weeks in the ICU with Dr. Nfonoyim. So as a 2nd year now, I oversee my interns, but our training in the ICU is amazing. We do a lot of procedures on patients, things like that. And really in the ICU, the technology to monitor these patients so closely is really, unimaginable. We can, check their blood pressure at real time. We can, when they're on their ventilators, we can adjust their settings to help them breathe better. So really, you see a lot of really amazing things that we can do.
So tell me the hierarchy, just the group that's there. So you're the PGY2. Is there someone above you? Is there someone supervising you? day and night. So tell us a little bit. Well, again, when I'm looking at our wonderful audience, people who I've been with for over 5 years, they want to know that someone is there watching them, and they want to know that it's a person who has experience day and night. So tell me, do you feel comfortable at night, during the day, having availability of someone who's knowledgeable about intensive care?
Right. So fortunately, or unfortunately for Dr. Nfonoyim, he's available to us 24/7. Typically, it will be me in the ICU with 3 or 4 interns. We kind of monitor everyone. If there's something that we think we can't take care of, or it's an emergency situation, then we could always find Dr. Nfonoyim and ask for his help, and he'll come right away.
Jay, tell me a little bit about the setup of an ICU. It's funny, not funny, but during the COVID pandemic, people weren't allowed in, aren't, still not, but weren't at that point allowed in with family members, which we did in the past. We encourage family members to help, to be there, to be consoling, to have music playing, to try to talk to patients, especially even in my field with neurological problems, to talk to the person, hoping someone in a coma would come out of it, trying to give them some inspiration. Now with COVID, it's been very difficult. So tell me a little bit how you're set up, and really ratios of nurses. What makes an ICU an ICU?
What makes an ICU is the resources, the human resources. You're talking of the physician staff, the nursing staff, the respiratory therapists, the dietitian, the nurse and nursing assistants, and everybody. And then the other thing is, the other resource is the technology that you have. Be able to monitor patients real time. Interventions that you can only do within the ICU that cannot be done anywhere else in the hospital, maybe in the operating room or the emergency room, but no other place in the hospital. So you have the monitoring, the technology, the expertise. And this expertise, I mentioned the people the team that comes together. The ratio for the nurses, you have 2 patients per nurse. And there are times when it's just 1 nurse per patient, depending on how sick that individual is, the level of monitoring and intervention that needs to be done.
And I think it's amazing, and really a shout out to all the nurses. I mean, we talk about frontline physicians, frontline EMTs. The nurses are so pivotal in taking care of patients. And you can't say enough. And I'll say something about my stroke unit at the hospital. What makes the difference between years ago when we had patients on a regular medical floor versus patients in a stroke setting, a stroke unit, there's one difference. It's the nursing ratio. It's, again, having technology, of course. But it's the same doctor, me, myself, and I were used to round upstairs, around in the unit. But in our unit, the ratio of nurses is twice as good, 2 to 3 times better than it is in the regular medical floor. And that difference has been shown in multiple studies to have people survive more, better outcomes, less disability. So the nurses are really the pivotal portion of what we're seeing, and of course the technology and your expertise. So Francine, tell us a little bit. You worked in the emergency room also. When somebody comes in, and again, there's always an emergency room attending or a senior physician.
Right.
How do you decide if someone goes, where in the hospital they go? They go to the intensive care unit? Do they go to a regular floor? How do we know?
Well, there's certain criteria that we look at depending on if we are going to actually admit the patient, and then if they go to a regular floor or an ICU unit. So for the regular floors, they're not too sick. We think we're comfortable with monitoring them on a room if they're okay with having, being in a room by themselves. And then once in a while, the nurses will come in and take their vitals. Whereas if we think somebody is so sick or requiring, oxygen support, blood pressure support, things like that, massive blood transfusions, then we'll bring them to the ICU where, again, we have these real-time measurements of their blood pressure and their oxygen, heart rate, things like that.
So Jay, tell us a little bit about when you decide someone goes into the intensive care unit, or actually when they get into the intensive care unit. I mean, we heard from Dr. Fu that there's certain criteria, and again, we're not going to belabor the criteria, whether how low your blood pressure is or how high your blood pressure is, whether you're breathing with any support, oxygen, non-oxygen, whether you've had a head trauma or you have a heart attack. So tell us a little bit about different units that we have at Richmond University and what different units are around, and really how do we triage where they go?
Okay. I think before I go into that, the ICU usually, to get into an ICU, there are two things. You go in there to be observed, or you go in there to get treatment. So if you get admitted because you have a condition or you present with signs and symptoms that say if you are not monitored closely, you might decompensate, or even if you are monitored, you could decompensate, you get into an ICU. Most of the patients admitted to most ICUs get admitted because of that. The second thing is, if you have a condition like you said, a stroke, heart attack, you need to be in a place where you can be monitored. Dr. Fu just mentioned patients whose blood pressure is low. Now, what ICUs do you have? ICUs, we have specialty ICUs. They have the medical ICU for the patients who are medical patients who are critical. You have the surgical ICU where you admit the trauma patients and the surgical patients who require critical care. And obviously we have the stroke critical care, which is the unit you run where you have your patients with stroke. We have the coronary care ICU as well for patients with myocardial infarctions and
heart attacks.
Heart attacks, yeah, thank you very much. Have heart attacks. Obviously, I'm an adult, I'm trained in adult medicine, but I still need to mention the fact that we have a NICU as well for neonates who need critical care.
So maybe both of you could tell us, how has COVID changed the ICU? Early in the pandemic, there was the idea that there wouldn't be enough beds, enough ventilators. Thank God we got through that situation early on, and again, hopefully the numbers are going down with the vaccine, and they are going down, but hopefully they're going down to very small numbers in the near future. So tell us how COVID changes things. Before we went on the air, you were telling me, I think Dr. Fu was mentioning to me about oxygenation is different with regard to patients with COVID and what our criteria are. So maybe you guys could both tell me, with COVID, how is it different? And if somebody is afraid, say someone feels like they're having a heart attack, and they know that they had a relative who went to the CCU, or the heart monitoring unit, the coronary care unit in the past, but they're afraid to go there because they think they're going to get COVID there. Tell us a little bit how you bring that out. So maybe first tell us, as we said, and we'll see what we could find out. So I'll let you go first. I'm sorry, that was a very long question. You're not supposed to put too many parts to a question. So I'll let you take whatever parts you'd like.
So early on in the pandemic, we were able to open additional ICU beds where we would keep only the COVID patients in those areas to prevent any sort of transmissions to non-COVID patients. And now we also try to do the same, try to keep all the COVID patients in one unit away from everyone else. But again, we do the proper isolation. There are negative pressure rooms, and we all wear the proper PPE.
And negative pressure rooms mean what? So
it's basically a machine in the room, or sometimes the room itself is designed to filter the air out. It's constantly just sucking the air out, and we're filtering it and replacing it with clean air, essentially. Another thing is our PPE, we wear it, or at least an N95, we wear it to every room now.
So PPE just for everyone, personal protective
equipment. So that's our gowns, our gloves, our face shields. And really, after the pandemic has started, we are much more cautious about interacting with patients and making sure we have all the proper PPE before we see anyone.
Mm-hmm. So Jay, if someone's worried, well, actually give me a little bit of the criteria to have how you get into an intensive care unit if you do have COVID. How do we decide where someone belongs?
Okay, if you do have COVID, present in the emergency room, your symptoms will determine where you go, and your risk factors for decompensation, say your age, you have a lot of comorbidities, you are more likely to be taken into the ICU because your chances of decompensating are a whole lot higher, so you'll be taken into the ICU. And the younger patients whose saturation is acceptable, required just nasal O2, a little amount of O2 might be sent to the regular floor. As Francine mentioned, we try to keep these patients, the COVID patients who are critically ill, in one area, and those that patients with other conditions are kept in other areas as much as we can.
Tell us a little bit about the team. I mean, I'll ask Francine to talk about the residents, and she mentioned them, other medical students. So, and then I want to ask you about all the people that work in an ICU, nurses, respiratory therapists, but maybe we'll talk about the medical team that's there.
Okay, so usually there's one senior in the ICU that would be that's usually a second year, so me, and then we have 3 or 4 interns. And really, again, as we mentioned, nursing ratio. In the ICU, every resident at most probably has 4 patients, as opposed to on the floors, they might have 9, double the amount. So really, you get a chance to focus in on your patients. They're critically ill, you know every aspect of them, and you have the chance to focus on these 4 patients and, treat them.
Treat them more.
Yeah.
So could you tell us about the respiratory therapists? I mean, we haven't spoken about them.
Yeah.
The idea of patients in the intensive care unit observed or they need treatment. One of the treatments is being on a respirator or having oxygen support. So tell us about what the respiratory therapist
The
does.
respiratory therapists make part of, a very essential part of the critical care team. A lot of patients in the ICU receive oxygen therapy by nasal cannula, mask, as Francine mentioned earlier, and as well as ventilators. The respiratory therapists are usually responsible for putting the patients on oxygen, taking them off oxygen, and making the changes on the ventilators that we request. So they are very integral and a very, very important part in managing patients who have respiratory failure.
I'm going to ask you sort of a 2-part question. It's really the same question. Patients who are critically ill, if you happen to be having chest pain, should you go to a local hospital? I mean, we're very proud of our institution. Our people training there well are marvelous. Do you feel that local hospitals, whether they're on Long Island, Brooklyn, I know you're a native of Brooklyn, so am I, Staten Island, different areas, or do they have to go to Manhattan? And if you do go into a hospital, should you ask that your patient, your family member, be transferred to a place that might have different technology? And I really want your answer, because so many of our people, and we first of all, the show goes to all of Staten Island. Then it goes all over the city. And the city includes all the 5 boroughs. So some people are just so concerned about getting proper care, and rightly so. But I wanted someone who's an expert in the field out here on Staten Island, sort of to tell our viewers, about the level of care that you feel people have, and do we, I'll use the generic we because we work at the hospital together, transfer people out for procedures that we need to have transferred out. So tell us a little bit about your feeling about the hospital with regard to the quality of care and whether people come here.
I'm happy you asked that. There's a tendency for individuals to think what is on the other side is better than what you have. I would tell you, personally, I'll receive care in Staten Island because I know the hospitals in Staten Island, the hospital where I work, the level of care is as good in almost every area as it is in the other boroughs. And I have to say this, you trained in the city. I trained in the city. So we didn't leave our knowledge back there when we came to the island. when we came to the island, so no, the care here is as good as it is in Manhattan. Are there certain things that we don't have, that we might not have? Yes, they are. Just like if I give you an example, something like ECMO. We're talking about patients with respiratory failure. If I need ECMO, those are things that have to be services that need provided in a specialty institution.
Tell us what ECMO is.
Yeah.
We gotta,
okay. So I send patients to the city for that. ECMO,
give us the initials. Extracorporeal.
Yeah. ECMO is extracorporeal membrane oxygenation, and basically, to make it simple, is most people know about dialysis. It's like dialysis for the lungs. You get 2 tubes, plastic tubes are placed into blood vessels, and blood is pulled from is pulled out by a pump, and it goes to a filter where is oxygenated because you cannot exchange oxygen. That blood is oxygenated. The carbon dioxide is taken out, and that blood put back into the patient. So those patients are usually on ventilators, but the ventilator is really not giving them oxygenation. It's just opening the lungs back and forth. But the oxygenation is being done outside of the body. So services like that, I'll send patients to the city for.
So there are some things that we do.
Yeah.
So, and that's marvelous to hear. I know, I believe, where did you go to osteopathic school?
So I went to Lake Erie College of Osteopathic Medicine out in Greensburg, Pennsylvania.
And so probably not a large city there.
No, very small. It was the first time I ever moved from Brooklyn. And I went there, I learned how to drive, and everyone was like, oh my God, where are you from? You don't know how to drive. So it was quite a shock for me. It was a small little town, but I think, you know.
And I'm sure you're training in a rural community, what I'm getting at,
yes,
compared to a metropolitan urban community. Tell us a little bit about the difference between the two.
I mean, definitely the patient load. There's a much higher volume of patients that we see, but also with that, you know, you see a lot of different cases, and that, I mean, for me, I'm able to learn about all these different cases as opposed to if I were in a more rural place.
Jay, now I want to go into what's cutting edge in intensive care medicine. We do this program every month, every 2 weeks, there's a new show. And what we do is we talk about new things in endocrinology, new things in MS, stroke. Tell us, you mentioned ECMO before, clearly that's one of the newer techniques. Tell us a little bit about newer things in intensive care.
Okay. I'd like to go back to what you said, and I'll add, talking about taking patients out of the island. I want to mention the fact that if the hospitals in the island, the certification that they need, say for trauma in a hospital in Staten Island, is the same requirements that have to be met by a hospital in Manhattan. The same for a stroke unit in Staten Island is the same requirement for an institution in Manhattan or in Brooklyn. So this criteria are the same. So wherever you go, if you have that certification, you can provide that care. Now, cutting edge things in the ICU. You mentioned ECMO. ECMO has been extracorporeal membrane oxygenation. It's been around for a long time. Initially there was a debate on whether it does help with adult patients, and we didn't get to use it that much. But right now we don't hesitate sending patients out if we cannot get them oxygenated adequately with all the support that is available. The other cutting edge thing is right now there's more emphasis on monitoring patients non-invasively. In the past, if you had to check the amount of blood, cardiac output, the amount of blood that the heart pumps, you had to put in a catheter, but right now you can do those things non-invasively. If you need to check whether your patient has enough volume, you do that with an ultrasound. Residents now, attendants in the emergency room, in the ICU use ultrasounds for almost everything. That didn't used to be the case. I remember when I was training, when you put lines, you did it blindly. Right now, you get an ultrasound to do that. You go to a patient's bedside, you put a probe around and figure out do they have enough, do they have something wrong with the heart, and it's really very, very different.
It's like a little echocardiogram.
Yeah, no, yeah.
Almost the stethoscope is becoming passe.
No, yeah. No, that is definitely true, and I like to expand on that a little bit. When you go back to history, when the stethoscope was developed, maybe 150 years ago, it was like, are you kidding me? Whatever happened to listening?
Right.
So now the stethoscope is about to go away, and I tell you, some of us, the old physicians, are really struggling to hold on to it.
I like my reflex hammer. I have to tell you this.
No, the reflex hammer is still working.
That I like very much.
The reflex hammer is still working.
And I still like touching patients because there's something about that unique relationship. And you mentioned it earlier, and different times we've spoken about telemedicine. They're very difficult to do that in the intensive care unit. Someone's actually has to touch the patient in order to see if they're swollen, to see what's going on. So let me tell you, we have a very vibrant neurosurgical program at Richmond University Medical Center. And I know we've got their programs around the area and in New York City, of course. Tell us about monitoring of patients after surgery for for people who have had brain surgery?
Monitoring patients post neurosurgery, besides the monitoring the blood pressure, monitoring the heart rate, monitoring how much urine they're putting out, you might need to do putting a monitor into the brain to monitor the pressure in the brain, what we call the intracranial pressure. So a catheter is put into the ventricles by the neurosurgeon, and you kind of use that to monitor what's going on in the patient's brain.
We're coming to the end, and what I'd like you guys to do is, and I really want to say this, as frontline physicians, all three of us, and you guys being in the hospital even more time than I am and seeing so many patients with COVID, how has it affected you and your families? You know, in a sense, I mean, I go to the hospital every day, and sometimes when I go home, my family tries to figure out why I shower 3 times a day sometimes. You know, and there's certain times I've gone into rooms where people have been very sick, and when I go home, my clothes might have been soiled, and I have to figure out what to do. And residents really have more scrubs, and they come in a little different apparel. But in a sense, how has it affected you and your family with regard to this?
I'll tell you, it's been very challenging. The way that's affected me, first emotionally, I always resist being emotional, teary, when I talk about my experience taking care of COVID patients, especially before. The other thing that bothers me, and I keep on thinking about it, is I did not realize how traumatized my wife was. She would call every relative and they would talk, they would cry together. I didn't know. My children took upon calling every day to FaceTime because they did not believe that I wasn't sick. And I'm happy they did that because they still do that now.
So what I'm going to let you do, and all three of us, I want you to say thank you, and we have all the air here. Please thank your family. So I'll thank mine. I'll thank my wonderful wife, Susan, my 3 kids, Harrison, Jacqueline, and Evan. I want to thank them every day for being there and for waiting for me to come home and being worried about me, and my mom also. And I wish everyone the best. So I'll let everyone give a shout out. We've got a few seconds.
I'd also like to thank my mom and my dad for always being there. I'm fortunate enough to live close enough to them where they can make me dinner. I could pick it up on my way back from work. I would also like to shout out to all my co-residents who have been there for each other working through this pandemic.
And Jay?
I'd like to thank my family, my wife, my children, and the support that I got from the residents and the nursing staff. I wouldn't be talking here, I wouldn't be here if I didn't have that support.
The team at Richmond University Medical Center, and I'll echo that too, have been absolutely marvelous. And with that, I want to thank everyone, and please stay safe. And the physicians available are wonderful, and I wish everyone the best.